pulmonary embolism. So they're asking what is the cause, what could be the reason for this patient developing stroke. So the answer is PFO, which is like incomplete fusion of atrial septum, primum, and secundum. So PFO, it's like we know that the thing that we usually get confused with PFO is that we have the septum primum and we have septum. This is primum, this is secundum, and we have something called ASD. In ASD, the problem is that either there is an endocardial cushion defect, so either there is no primum at all, or rarely it could be secondum defect. In those cases, it is different. Even those patients, they could have present with similar symptoms. Just like this patient, they will have a stroke symptom and they will have a little note about the pulmonary embolism and they will ask you the cause. And in that case, they will mention something about the what do you call it? The ASD murmur, the white fixed splitting, something like that. They would measure. They will show it in that question. But in PFO question, it will mostly be a normal patient. Hello. Yeah, yeah. I heard some noise. Yeah. So in PFO question, it's mostly going to be a normal patient, just like this patient. So we have three components in questions like this. Like they will have a pulmonary embolism component, or sometimes it could be an hypercoagulability component, and second component is the stroke component, and the third one mostly it will be like the answer, which will be either PFO or ASD. So in pulmonary embolism, some questions will concentrate more on the pulmonary embolism. They will say the patient had like a right leg swelling or left leg swelling or a unilateral leg swelling, and some patients they will have like their OCP use or something, like they have migraine patients, they have been prescribed with some drug that increases the hypercoagulability, something like that. So they will, some questions will concentrate on this pulmonary embolism hypercoagulability concept, and they will give a word about stroke. The patient developed weakness from this morning, something like that. Or some questions, for example, this question they concentrate more on the stroke component. They explained detailed about the stroke, that he had right arm weakness and something like that, and they might have sometimes aphasia and things like that to express the cortical involvement. And the answer in most cases will be PFO or ASD, and that is mainly dependent on the murmur and the white fixed splitting that we discussed before. Okay, so we will see what is like PFO. So now for that we will have a quick note about the fetal pathway, what happens in the fetus when it is born. And when the baby is inside the mother's womb, you know that there is like the pressure on the left side of the heart is lower because the aorta is connected to the umbilical vessels in that case. So umbilical vessels in turn is connected to the placenta. So placenta is a low vascular resistance system. So you will have a low left heart pressures, and there will be high right heart pressure. The reason is because pulmonary vessels are not yet opened up. It is filled with fluid and the resistance is very high. So the pressure is very high in the right heart and the pressure is very low in the left heart. This means that in the blood will be flowing from the right heart to the left heart directly, instead of the blood flowing to the right ventricle and then moving on to the pulmonary vessels. So this is what happens inside the baby. But after, when the baby is born, what happens is that the placenta is gone. So the systemic vascular, the since the placenta is gone, the systemic vascular resistance is increased in these patients. And also the baby starts to breathe and the fluid is getting cleared from the lung. So the pulmonary vessels starts to dilate and the resistance falls. And this leads to the blood from the right ventricle moving into the low resistance pathway, that is to the right ventricles and to the pulmonary vasculature, instead of it going through this small defect, that is PFO. This causes that the primum septum and secundum to cross across each other. It's like they both will just get attached to each other here, like I said. It will get attached to each other. Initially it will be like a functional closure, and as days goes by this will get fibrosed and everything, and then they will completely close. So this is what happens when the baby is born. So to find if the patient is still having a PFO, like if an adult, like they've said mentioned here that there is like 25% of adults and even 30% of adults have this PFO, but we don't know it. The reason is because even if a PFO exists, because of the increased pressure on the left side of the heart, there will be no mixing of the blood. It will be like they will be at total different pathways, and there's no mixing of the blood except of times like where the right heart pressure increases, like the Valsalva maneuver that is mentioned here. So we are using this this physiology here to diagnose this condition. How are we going to diagnose this? We are going to diagnose it with a test called bubble study. It is nothing, just you introduce a bubble into your intravenously. That is like you give a saline which is very agitated, which is not in a normal, laminar flow. So this agitated saline, you do an echo and see if there's bubbles that is moving from the right heart to the left heart. So if you find a bubble moving from a right heart to the left heart, which means there is a PFO, that's how you diagnose it. And that movement will happen only when you put the patient to increase the right ventricular pressure, that is right side of heart pressure. That you do it by doing Valsalva maneuver. So they say like in the release phase of Valsalva maneuver, you will see that bubbles moving from the right atrium to the left atrium, and that's how you diagnose the PFO. So these are all like the extra notch information, because they don't usually ask about like explain the what happens to the baby when it's born or what happens in the PFO, nothing. But the questions will be in this format, that is either pulmonary embolism or hypercoagulability concept, and then there will be a stroke concept, and then they will ask you the answer. It's either going to be PFO or ASD, and that depends on the patient's murmur or his symptoms before all this stroke happened. So, okay, you're clear till here? Yeah. So I usually ask a lot of questions when I go through, but it feels like a more of a monotonic presentation right now. Okay. Okay, fine. So here they've mentioned something about what are the hypercoagulability state, like they mentioned OCP use, that could be in the question, that could be a clue. And one more thing you want to know is that, so chronically elevated, you might think that if a patient with a chronically elevated right heart pressure, that is like Eisenmenger syndrome, that's when that's when an embolism, pulmonary embolism, can move and cause a stroke. But that is not the true. Even with maneuvers like Valsalva maneuvers can cause little amount of blood to move from the right side of the heart to the left side of the heart, even in a normal patient with PFO. So in that, if a patient is having pulmonary embolism, then it is a high chance that these embolism may move during this Valsalva maneuvers and they can cause a stroke. So that is also something you have to know. And next concept that we are going to discuss here is, I think I covered most of that in the page. And the next concept that we are going to discuss here is the PDA. So we finished the patent foramen oval, this, which is a very different concept from the one we are going to discuss, that is PDA. In the PDA, what happens is like normally in normal fetus, there is this connection between the aorta and the pulmonary vessels, right? Pulmonary arteries and aorta, there is a connection. So this connection is, the reason for this connection is, even though, like I said, the right atrium and right ventricle, it is not function, the blood from the right atrium is not going to the right ventricles in a baby. It straightly goes to the left atrium through the patent foramen ovale, which is normal in a baby, in a fetus. So what happens is still a little amount of blood, because of gravity, they will go to the left ventricle. But this blood has no purpose, because the pulmonary vessels in the lungs are completely closed. So we have to save this blood. We don't have to want to waste this blood. But so this blood through the pulmonary vessels will be transported to the aorta again with the help of this patent ductus arteries. That is ductus arteries. This patency happens only when the baby is born. So this ductus arteries helps to transport the blood from the pulmonary vessels to the aorta. So what happens, this thing you have to remember is that what happens in the fetus, from where to where the blood is passing, from the pulmonary artery to the aortas where the blood is passing in a normal fetus. But what happens after the baby is born, the pressure, this, the reason for this is like in the fetus, the pulmonary artery has higher pressure compared to the aorta, because aorta is connected to the placenta. So it's a low pressure site in case of a fetus. But what happens when the baby is born? Baby is born, the aorta has a pressure, increased pressure. You know, the aorta is like 120/80 pressure, right? So what happens to the pulmonary artery? The pulmonary artery pressure falls because the baby is breathing. So the pulmonary vessels dilate and everything. So this pressure will be somewhere around 25 something. So if this ductus arteriosus is being patent in a fetus, in a baby which is already born, then the movement of the blood will not be from pulmonary artery to the aorta. It will be from the aorta to the pulmonary artery. It's from the high pressure to the low pressure, right? You got it? What I'm saying? Yeah. So if you should be clear about this concept. So this is the reason why when a baby is born, if there is a patent pulmonary arteriosus, you will hear a continuous movement of continuous motion like murmur throughout systole and diastole, because this blood is moving from aorta to the pulmonary artery throughout systole and diastole, because this is not a some pathological defect that is inside the heart, it is outside the heart, so it doesn't depend on the systole and diastole, and there is this continuous murmur that you hear throughout. Okay, so but this question that we are going to see right now, it is not connected to the PDA's defect. It is utilizing PDA as a benefit for the for their defects. Okay, so there are some conditions called cyanotic congenital heart diseases. So what happens is in some patients, in some babies with these cyanotic congenital heart disease, which I will come back again. So what happens is they don't have a proper blood flow from the right atrium to the right ventricle to the pulmonary arteries. There is some kind of pathology in this region. Okay, so this blood is not passing through to the pulmonary arteries. Instead, some defect, this blood is passing straight away to the left heart. Okay, so what happens in a adult, sorry, what happens in a newborn in which blood is passing from the right side of the heart to the left side of the heart without getting oxygenated to the lungs? What happens? It is like a cyanosed blood, right? It is an unoxygenated blood. So that is a cyanosed blood. Okay. So the baby presents with cyanosis in these cases. Okay. So the only factor that is preventing this cyanosis, or the only factor that is helping the blood to get oxygenated here, is that PDA. This PDA, which is being patent, will still help the blood to pass from the aorta to the pulmonary arteries, and the pulmonary arteries will oxygenate the blood, and the blood will return to the left heart, that is left atrium and left ventricles, and it can reach to the systemic circulation, and the baby is getting somewhat a better oxygenation. But like I told you, like the PDA will close at 24 hours. Like 24 hours, there's like functional closure. Like let's say it just closes, but it's not obliterated. But a few weeks, like say 1 to 2 weeks, it will be like completely obliterated. Okay, so what happens in this patients with this cyanotic congenital heart disease babies who are dependent on this PDA for the blood to get oxygenated? At 24 hours, they will start to get symptoms, which is, what are the symptoms? Those symptoms will be cyanosis, or those symptoms will be like the babies will not have a better oxygenation even with 100% O2. You administer 100% O2, and still the baby is not increasing the SpO2. So these are the things that the babies will have when they are having like PDA closure in a cyanotic congenital heart disease babies. Okay, so let's see the question stem. Usually the question stem will be like a baby which is born normally, no cyanosis, but in 24 hours they're developing cyanosis. And how the cyanosis will be? This cyanosis will not improve with the O2. I want to just give a side note here on, can you tell me what are the conditions which does not improve with 100% oxygen? The hypoxia which will not improve with 100% oxygen. Hello. Okay, so when, yes, cyanotic congenital has, the most important thing is cyanotic congenital heart disease. That's true. But what happens is when you finish the lung questions and then you do a CVS questions together, you will think about pulmonary embolism, pneumonia, all those conditions. The thing is, any let's keep it two different things. That one is lung condition, the other one is, yeah, the other one is heart condition. Yeah. So the lung condition, more. Yeah, most of them will improve with 100% oxygen, except two. Just keep it clear. They will have a huge table and they will give improves, not improves. Just keep it straight. All the lung conditions will improve with 100% oxygen, except the two conditions, that is large pulmonary embolism. Can you tell me what is the other one? Yeah, large pneumonia. Yeah. Large pneumonia in the sense that the kind of pneumonia that you get with COVID and influenza, like the entire lung, both lungs gets affected. Only those cases, and in a very large pulmonary embolism, which is big enough to cause the patient to collapse and go undergo cardiac arrest. Only those conditions will not improve with 100% oxygen. All the other conditions, lobar pneumonias, even small pulmonary embolisms, and all the other conditions, they should improve with 100% oxygen. Okay, so that you can keep it clear. And the cyanotic heart diseases are the ones which will not improve with oxygen. The reason is because this the blood is not at all reaching the lung, so how much ever oxygen you give is gonna go waste. Okay, so 24 hours, baby is developing cyanosis, and the extra clue is 100%. The SpO2 is not improving with 100% oxygen. That is the extra clue. And one more thing is, if it is a pulmonary embolism or pneumonia or any lung issues, the baby will have like retraction, they will have nasal flaring, and the difficulty with breathing and all those symptoms. Those things we are not having it here. So the cyanosis is because of heart. We are clear that. And one more thing is, the baby was fine when it's born, and the cyanosis developed only at 24 hours. So it has to do something with the PDA, so ductus arteriosus, because at 24 hours, something that happens is significant even in a newborn is the closure of the PDA, right? So that is going to happen at 24 hours. So if these symptoms are happening at 24 hours, has to get something to do with that. So that is the thing. So the treatment is to maintain the PDA. Can you tell me what are the two things that that causes the closure of the PDA? Physiological thing. What? No, no. I'm like in a molecular level. The oxygen, the improved oxygen in the blood, and the prostaglandins, right? Yeah, these two are the things which is causing this closure of this PDA, physiological closure. That is the functional closure of the PDA at the 24 hours. Okay, so we have to give one of these two things to maintain the patency. Okay, you can also remember that like not all babies with cyanotic congenital heart disease will develop worsening symptoms of sinuses at 24 hours. The reason is they already have a sinused blood, they already have a low O2 in their blood, so that itself will help them maintain the patency of the PDA to some level. But some babies, they have an exceptionally good PDA and it closes at 24 hours unnecessarily, and in those babies we give treatment in the form of PGE E1. Okay, you can remember the prostol. I think it's aldoprostol or something, but they will. It's mostly be straightforward questions. Okay, prostaglandin E1. You're gonna give them prostaglandin E1 to maintain the patency. Okay, that's done. Okay, now I have to tell you what are the cyanotic congenital heart disease that will depend on this PDA. That is the one concept that we skipped while we are discussing this question. So I usually keep it as T5 to keep it as straight. Like one is truncus artery. Transposition of great arteries. The other one is tetralogy of Fallot. The other one is tricuspid atresia, and the other one is total anomalous pulmonary venous connections. And one more is truncus arteriosus. So these are the cyanotic congenital. There are a lot of congenital heart diseases, right? There could be AST, there could be VST, many things, but they don't cause cyanosis. If something causes cyanosis, it's mostly going to be one among these five T's. Or there are some extra things you can remember. One is hypoplastic left heart. This is like too much. Anyone can say that hypoplastic left heart will cause cyanosis because left heart is completely gone here. So hypoplastic left heart disease is one more condition. And one more thing that I want you to remember is critical coarctation of aorta. What is this critical coarctation of aorta? So we will have a quite small discussion about that here. So coarctation of aorta, we have a constriction in the aorta that we know. What it is in two types. What differentiates is whether this obstruction is above the PDA or is it below the PDA. So let's say the obstruction is above the PDA. Okay. So what happens is here there is an obstruction from the aorta, but there is still PDA present. So this PDA will transport the blood, and this blood will reach the lower limbs and everything, and it's compensating the baby. Okay, so the baby's all the parts of the baby is getting blood because the PDA is still patent in the baby. Okay, but this is the type of. But what happens if there is a constriction which is below the ductus arteriosus? If the constriction is below the ductus arteriosus, then the baby is not getting, even as a fetus, it is not getting a blood. Okay, so they as a growing fetus, they will adapt. So as a process of adaptation, there will be several collaterals forming around this coarctation. Okay, yeah. So in this babies which had a coarctation, that is after the PDA, who had the collaterals developed, they will not have any symptoms when they are born. They will not have this differential cyanosis and all those things. Okay, mostly they won't have. But what happens to these babies who had a PDA which was providing them with blood to the lower limbs during the fetus, but when they are born, this PDA is closed, right? These are the babies who will undergo cyanosis after at birth. Okay, They will undergo differential cyanosis. That is the limbs will turn in color, and that will happen at what time? That will be happening around 24 hours as well. Okay, this is one more concept you can remember, because they might ask a question like a baby is born well and they have developed differential cyanosis. Okay, I want to give one more discuss about something else here as well. So can you tell me the differential diagnosis for the differential cyanosis? Yeah. So differential cyanosis, there are few conditions, but the things that is important they will ask in UWorld or in the step two is the two things. One is persistent pulmonary hypertension. Okay, this you would have seen, like if you have done if you're almost done with the UWorld, you would know that there are a lot of questions with persistent pulmonary hypertension. So in a newborn child with differential diagnosis, first thing that will come to your mind should be persistent pulmonary hypertension. Okay, so they have a persistent hypertension in the blood vessels, they in the pulmonary vasculature, which is not going down even after the baby is born, because the breathing is not happening properly, and this will lead to cyanosis. Okay, they will have differential cyanosis. So always think about this as a first diagnosis, and then second will be coarctation of aorta, obviously because there is lower limb is cut off of blood, right, because of the coarctation. This, but what happens in coarctation is they will give some extra clue for you, like the baby is having increased blood pressure in the upper limbs, or there is notching. They will have that ribs will have figure of three appearance, you remember everything? Yeah. Yeah, because of the blood vessels is going in the lower surface of the lower surface of the ribs, they will have form a notching because of the increased blood pressure in these vessels. Okay, so this is called figure of three appearance or something. Okay, so the at the baby, if it is an adult, they will tell you about the headache and those symptoms, renal failure and everything. But in babies, it's mostly going to be increased blood pressure or rib notching and everything. Okay. Yeah, so this is something side note you can remember. So differential cyanosis, first thing is persistent pulmonary hypertension, and the second thing you can remember is coarctation of aorta. Why we discuss this? Because 24 hours even coarctation of aorta is going to cause differential cyanosis because of the closure of the PDA. So the critical coarctation of aorta is the one which is like the coarctation of aorta was before PDA. That is called pre-ductal coarctation of aorta. That is the one which is mostly PDA dependent, which will cause symptoms at the 24 hours. Okay, got it. So the remaining of the conditions will be either this T5, one of these T5 conditions, or it will be like hypoplastic left heart. Only these things are the cyanotic heart conditions that will depend on the PDA. So they might give. So the why I'm saying this is they will talk in detail about one of these conditions, and the question will be about the prostaglandin E1 or about the PDA. Okay, so you might be getting carried away from this either this TGA description or about the tetralogy of Fallot description that they are giving in the question, and you will not concentrate on the what they are actually asking, which is the treatment, which is prostaglandin E1. Got it? Yeah, I think we can move on. Let me see if there is something else there I've missed. Yeah. So one more thing is, not all patients, as you can see in this question, they have not said anything about the murmur. There's like zero, no murmur in this patient. You might say like the PDA is like, if they are talking something about the PDA patient, like a baby is having PDA, then they will say something about the continuous motion like murmur. But here the PDA is closed. That is what is causing all the symptoms. So in this patient, they might not give you the symptom for the PDA. And in some questions where they want to be very straight, they don't even mention about the murmurs caused by any of these conditions. You might ask like tetralogy of Fallot will cause murmurs. It will cause either VSD murmur or it could cause pulmonary atresia murmur, but none of this is mentioned here. Like most of the time they don't mention it. Okay, so just because there's no murmur doesn't mean this is not a cyanotic congenital loss. This is a cyanosis because of a lung disease. No, you should not get confused in that point. Okay, sometimes there will be no murmurs that is mentioned. Okay, yeah, so let me see if I missed something. Yeah, let's move on to the next question. Yeah, so this question, I know that you put in a lot of questions about which branch of the blood vessels is getting affected in MI, but most questions I have seen either in NBMA or an actual exam, mostly the questions with MI will be about the treatment. What will you give this patient? Okay, they will not concentrate about which branch. I think you will hardly get one question or two question in NBME, but no, yeah, this is mostly like a step one question. Yeah, but they will ask about the treatment and they will ask about the complication. This is one thing. One more thing. Yeah, they might ask about complication and they might ask about the associated side effects. Okay, that I will tell you what it is. I just call it associated side effect. It's just another form of complication as well. So, just a brief review about what happens. Like, so V1, V2, V3, V4, V5, V6 are anterior and lateral leads, and one and AVL or lateral leads. Okay, and then three AVF and two or inferior leads, and AVR is the right-sided lead. Okay, so let's see first. Let's see about the anterior MI. So in the anterior MI, we all know that anterior MI is either going to be left anterior descending artery or the left lateral circumflex artery, both of which are branches from the left main branch. But sometimes what happens is you get confused if you want to answer. So for example, this question, they've given both left anterior descending artery and both left circumflex artery. But the question was about an MI patient who came in with ST segment elevation. Let's see where. Um, Actually, in V1, V2, V3 to V6, he had in everything. So they have given in the option both left anterior descending and left circumflex, right? So you can both actually give both the answers. But the thing how you differentiate is you see whether the patient is having V1, V2, V3, V4. If the anterior leads are affected, it's definitely LAD. It doesn't matter like if the lateral leads are affected or not. But if the lateral leads are affected, see if the anterior leads are also affected. If the anterior leads are also affected, then you go for LAD. If the only the lateral leads are affected, that is only V5, V6, 1 and AVL are affected, then you go for lateral circumflex. You got it? Yeah. So that is the way you answer this question if in case they ask us. But most of the time, they will ask for the inferior. Can you tell me what are the leads that is affected in the inferior MI? 2, 3 AVF. Okay. So what can you tell me what are the complications that you can see with an inferior MI? What can you expect in a question with inferior MI? Not the plain chest pain or anything. So what happens is the inferior MI is caused by which vessel? It is caused by the right coronary. Yeah, posterior descending artery, which is a branch of the right coronary artery. But sometimes it may not be actually the posterior descending artery that is getting affected. It could be the right coronary artery itself which got affected. So if the right coronary artery is affected, then the entire right ventricle depends on the right coronary artery. So the right ventricle cannot function. So the right ventricle will go in for failure. So right heart failure happens. This right heart failure patient, how do you differentiate an inferior MI from a right heart failure? Like if the patient is having right heart failure or is just an inferior wall MI. So you have to look at the blood pressure of the patient. If the patient is having low blood pressure, or if the patient is having low heart rate. Why is the heart rate? Because the right coronary artery is also something which supplies the SA node. If the SA node is getting affected, the heart rate will fall. So if either the heart rate is low or if the BP is low, in both of these conditions, you have to think about a right heart failure because of the right coronary artery which is getting affected instead of just an inferior wall MI. Got it? Yeah, so even that will not be a question most of the time. They will ask you, how will you treat this patient? Okay, this is a right heart failure, right? Okay, how do you treat a left heart failure? Can you tell me that? What is the treatment? True basic treatment, usual treatment, anybody can tell. What is that? Left heart failure, patient comes to you, you see a left heart failure, you see the patient is having crepes in the basal crepes, and he's having, edema. Yeah, yeah, diuretics. You give diuretics, you give nitrates. What is the reason behind giving this? Yeah, very good. Venous state. But what will you treat the right heart failure patient? You should not, one thing you should remember is do not treat them with anything that lowers the preload. Okay. That is very important. The same treatment, you should do the opposite in the right heart failure, because right heart failure patients, they already don't have a preload because the right heart is not functioning. So left heart is not receiving blood from the right heart, right? So they're already preload dependent patient. It's only the preload that is giving little bit of blood to the left heart that is causing a little bit of cardiac output, right, in this patient. So if you give them diuretics and nitrates, and already if you pool all the blood in the lower limbs or just send the blood out of your body, then what happens is preload is even more decreased and the cardiac output is dangerously decreased, and this is like very dangerous in right heart failure patients. So first thing is, you should not answer diuretics and nitrates, remember that thing. And second point, what will you give in these patients? What is the treatment? Yeah, it's like IV fluids. You just give them preloads. Remember, in left heart failure, preload should be reduced. So you give the patient with diuretics and nitrates. This is the normal heart failure that you see in most of the patients. How will this left heart failure patients present? They will have CREPS and they will have heart failure symptoms like edema and everything. Okay, and but the right heart failure patients, they are preload dependent patients. They need preload to maintain the cardiac output. So in these patients, you should definitely not give diuretics nitrates. Instead, you give them preload. That is, you give them IV fluids, which will increase the preload. Okay. So how will this right heart failure patients present? They will be MI patients. There will be two ways in which these patients can be present. Either it will be an MI patient who will have hypotension, or or will have low heart rate. That patient is a right heart failure patient. Or it could be a patient with edema and increased JVP, or sometimes even ascites or liver edema, and plus clear lungs, right? Clear lungs is the clue, right? Sometimes it's not, right heart failure doesn't have to be like MI all the time. It could be isolated right heart failure as well, like restrictive cardiomyopathy and everything. So in those cases, you will have a clear lung. Remember one more thing. I saw in this question, one of these questions down, where they described a right heart failure patient who presented with symptoms, MI patient who went in for a right heart failure, but he presented with symptoms of shortness of breath and lightheadedness. You can explain lightheadedness, right? Because it's because there's low blood pressure, there's low cardiac output that is causing lightheadedness. But the remember, the lungs are clear, but that doesn't mean he will not have shortness of breath, because the lungs is not receiving the blood, right? So it needs blood. Basically, he's having reduced cardiac output, he's having hypoxia. So the normal reflex in the body is to increase your breathing, right? So that will be there. So don't get confused, because there is shortness of breath doesn't mean it's a left heart failure. It could still be right heart failure. Okay. So it's just an extra point. Yeah. So basically, right heart failure, the treatment is IV fluids. Left heart failure, it's diuretics and nitrates. Right heart failure, the clue is clear lungs. One more thing, MI patients, inferior leads are getting affected. Look for hypotension and heart rate. If they are affected, then it is the patient is having right heart failure. So treatment will be IV fluids. Got it? Clear? Yeah. So same thing. Let me check if I missed something. Yeah, here there is one more thing. So in this question, it's all the same question. Here they mentioned about lights occlusion of the circumflex artery. So they have leads, I think. Yeah. One second. Yeah, so they have leads 1 to AVL, which was affected. So it is obviously circumflex artery. There's nothing new in this question. And in this question, they mentioned something about S4 heart. Actually, you can see this S3 and S4, the conditions that is causing it in the U world, and it is a little bit of an high yield. So I will tell you here what are the conditions that causes S4. S4 is something which happens when the blood from the from the left atrium hits the ventricle wall, which is very thick. Like, for example, I am putting some blood in a very stiff metal plate. It is because of the blood that is hitting the stiff ventricles that is causing the S4. So what are the conditions which have a stiff ventricles? A ventricle which is like a plate, very rigid. Those will be, first is the diastolic heart failure. This is the most common condition. Diastolic heart failure is what is that? Concentric hypertrophy, right? Becomes thicker. Yeah, in that thick ventricle, when blood is hitting that ventricle, that can cause S4. Okay. One more thing is, but which we usually forget, is the MI. Is also like the wall, the ischemic wall becomes like a thick board. In that condition also, when the blood hits the ischemic part of the ventricles, that will cause S4. Okay. That is for S4. This is the simple way to remember it. And then the S3 is when there is an overfilled ventricles, when the blood enters this overfilled ventricles. It's like there's an overfilled water bottle, you're trying to pour in water in that, and that is the S3. Okay, that is when S3 happens. This is very simple. When does S3 happens then? It's heart failure, right? Left ventricle failure, dilated cardiomyopathy. They can give any name to it. It's basically the concept is overfilled ventricle. So left ventricle heart failure or dilated cardiomyopathy or this condition S3 will happen. So sometimes they might mention it in the question as well. You can use it as a clue, but remember that both of the this S3 and S4 can happen on the right side of the heart as well. Okay, so it's not to differentiate between right or left. It's same. It can happen in the right side of the heart as well. It's just to differentiate if it's a concentric hypertrophy or if it's a dilated cardiomyopathy. Okay. And remember, MI also has S4. Okay, that's why they have mentioned S4 in this question. It's one more thing I wanted to discuss. And as you can see here, they mentioned right coronary artery and the ECG leads that were affected. Yeah, so here they have already mentioned it's right heart failure, and I think they have mentioned something about I don't know what this question is about. ECG at rest shows left ventricle hypertrophy. Okay, I don't think it's much difference. It's just the right coronary artery failure. Okay. Okay. Next, the next thing is okay, this thing we've discussed sinus bradycardia and hypotension because of right heart failure and sinus bradycardia because of SA node. They are saying sometimes you can see AV nodal block, but that is not that commonly. I've not seen it in any question. Yeah, one more thing. This thing I wanted to mention is that I've not seen it in many questions, but they do mention that here, how the interventricular septum, it is like it can be divided into two portions, like anterior portion and the one behind is the posterior portion. And the anterior portion is supplied by the left anterior descending, posterior portion is supplied by the PDA because PDA basically passes through the interventricular groove, right? So it can just give the blood to them. So PDA supplies the posterior part and LAD supplies the anterior part. So what they're saying is if LAD gets affected, this anterior part of interventricular septum will get affected, and that is the part where the Purkinje fibers are going in. Remember the fibers which supplies the ventricles, yeah, conduction fibers. So if in case that those will get ischemic as well, if they are affected, that's when the Mobitz type 2, that is second degree heart block or even third degree heart block happens. So just because we are in this topic, let's have a quick discussion about that as well. Okay, so but here they mentioned something about like the LAD affected causing Mobitz type 2. But can you tell me what is the most common cause for Mobitz type 2 and complete heart block? First, we'll discuss about the cause. Hello. So the most important cause is aging. Yeah, aging. So let me tell what is the thing that differentiates type 1. Type 1, I think you know about this. The type 1 is the one that is PR elongation. It's just a PR getting elongated, but it is fixed for every heart rate. Okay. That is, for example, the PR is like dilated by 2 mm. It is the same for every heartbeat. Okay. It's not changing. That is the type 1. And the more this is like type 1 heart block. Okay. Next, in the type 2 heart block, there's Mobitz type 1, Mobitz type 2. Okay, this is type 2 heart block, Mobitz type 1, Mobitz type 2. Okay, Mobitz type 2 is the one where you will have like a fixed, the PR keeps elongating. Like for example, in the first beat, there is like 1 mm dilatation. For in second beat, there is like 2 mm elongation, and third beat 3 mm, and then finally there is no QRS wave at all. It's just P wave. There's no QRS wave at all. That is the Mobitz type 1. Okay. And then the Mobitz type 2 is that the PR interval is constant, but suddenly there is a missed beat. That is the Mobitz type 2. And type 3 is that there is no connection between the atrium and ventricle. Ventricle is contracting on its own pace and atrium is contracting on its own pace. There is no connection between the conduction in the atrium and ventricles. Okay, so they will be having here the RR interval will be. I'm just assuming that you know all this, so I'm just quickly going through it. You want me to explain it slow? It's fine, right? Yeah. So there's no connection between so there's no connection between the atrium and ventricle. Here the RR interval will be normal, because the ventricles are contracting from this by getting signals from the ventricles, not from the AV node or from the SA node. Okay, so the RR interval will be normal, but only thing is you will not see a P wave, or the P wave will be retrograde P wave. It will be either no P wave, and the P wave will be like merged with the QRS complex. That's how it will be. Okay, so these are the 4 types, right? So I will usually divide like type 1 and Mobitz type 1 as together, because they are usually asymptomatic or very mildly symptomatic, and the cause for them is mostly drugs. The patient will be taking something that is already delaying the AV node. What are the things that delay the AV node? Drugs. Hello, hear me? Yeah, beta blockers, calcium channel blockers, digoxin, or athletes. These 4 are the constant causes of type 1, Mobitz type 1, and yeah, athletes. Yeah, it's basically, you can remember as vagus. Whatever that delays the AV node, vagus nerve will delay the AV node. Athletes will have a high vagal tone that is causing the AV nodal delay, and that is causing this disorders. Or beta blockers, calcium channel blockers, digoxin, all this will delay the AV node, and that will cause these disorders. So basically, the treatment for them is either to stop the drug or just no treatment at all. So when they ask something, mostly they will ask about the treatment. The treatment in most cases in type 1 and Mobitz type 1 will be no treatment at all, or just stop the drug that is offending. Okay, that's it. So I explained all this to say about the treatment. Okay. So what happens in Mobitz type 2 is it's the actual pathology happening only in the Mobitz type 2 and complete heart block. Here, the conduction system, like for example, SA node, AV node, the conduction system itself is affected. Like the conduction system either undergo atherosclerosis, or it had like in this LAD-MI case, or it had undergone fibrosis in an old age. Old age is the most common cause, because you remember pacemakers, we place pacemakers, right? We don't place pacemakers in young patients. Mostly it's old age patients that we place them in pacemakers, right? So that you can remember. So aging is the most common cause. That's why. Okay. So aging is the most common cause. So this conduction fibers undergoes fibrosis, and that causes the Mobitz type 2 and type 3. They are always symptomatic. They will have like hypotension. They will have giddiness, all those things, and reduced heart rate and all those things. So aging is the most common cause, or sometimes rarely they might mention LAD getting affected, and that is causing ischemia to the conduction fibers, and that is also causing Mobitz type 2 complete heart block. Okay, so what is the treatment? I already mentioned it, I guess. So it's pacemakers, yeah. So Mobitz type 2, type 3, always pacemakers. Answer is pacemakers. Mobitz type 1 and type 1 heart block, the treatment is either stop the drug, or if there is a no treatment, that's also fine. Okay, done. Hello. Yeah, so we are clear for till that. So why I said is it is one of the complications. So far we have seen what are the leads that can cause MI. I mean, what are the leads that will be affected in different types of MI? We saw the complication for right coronary artery. That is 2 things: right heart failure or SA node getting affected, causing low heart rate or BP. We saw the treatment for the right heart failure and left heart failure and how to differentiate it. Remember the preload dependent right heart failure, we have to treat it with IV fluids. IV fluids, that's very important. You will have many questions from that. Yeah, one more thing I want to discuss is this. I mean, it's very rash to ask LAD associated with Mobitz type 2, but it is very common to ask the treatment of Mobitz, different types of Mobitz and the treatment. Okay, they will just give you an ECG lead about either you have to find it if it's Mobitz type 1 or type 2 or complete heart block, and you have to find the treatment. Mostly it's treatment, and treatment will be pacemaker. Remember that. And we will here, I think it's one more question, right heart failure question. It is like straightforward question. You can see that there is 2, 3 AVF inferior leads are affected. But you can see in the BP is low and the heart rate is low, which means the patient is having right heart failure as well. Okay, what will be the treatment? IV fluids. That's it. Yeah. So yeah. So there's one more question about LCA, and I think it's all the same. You don't have to go through it. Yeah, so like I mentioned, they mentioned here jugular venous distension, crackles, all this will be here in left heart failure patients. Like LAD can cause left heart failure. Yeah, this is a nice segue into what are the complications. You will get a lot of questions from complications of MI. Can you tell me what are the few complications of MI? Everything will rupture. Just you can remember it that way. First, the papillary muscles will rupture. That will cause MR, and that can cause heart failure. And then the interventricular septum will rupture, and that can cause ventricular septal defect, and that can cause murmur and heart failure. And third thing rupturing will be free wall. That is, the free wall of the ventricles will rupture, and that can cause tamponade, or that can cause cardiac arrest and death. Okay. And apart from this rupture thing, the thing that we will see is what is a pericarditis and then aneurysm. You remember them? Yeah. So they will have a timing for this. Let's see. When the topic comes, okay, fine. Yeah, we can discuss it then. Okay, so yeah, so all these ruptures will happen, and you can get pericarditis, and you can get aneurysm, and yeah, the thing is they might mention one of these things, like they will mention the inferior leads are affected and everything, and they will mention one of these complications. And the important thing about this complication is like, everything will have a same moment, like papillary muscle rupture, MR, they will also have what is that? What is the murmur for MR? Uh, Halosystolic murmur, sorry. Holosystolic murmur, no. It's a holosystolic murmur. And VST, it's also the same holosystolic murmur. So you should just be able to differentiate between them based on the, what do you call it? Here, most of the MR patients will have acute heart failure. Based on that, you can be differentiate these things. Okay. And then tamponade and cardiac failure, I think you should be able to differentiate. And then make sure you, when you see these questions, look at the timing at which these happens. Most of them happens 3 to 5 days. Remember that free wall rupture can happen up to 2 weeks, and these three things can happen in months. Up to 2 weeks. Okay, it can happen in 2-3 days as well. Okay, so these are quick revision. So an MI question can go in any direction. MI question can go in a right heart failure direction, they will ask treatment about it, or an MI question can go into one of these complications, or an MI question can direct you into a heart failure, either right, even left heart failure, and they might ask treatment for the left heart failure, which is diuretics and nitrates. Okay, so all these are the ways in which an MI question can go. Yeah, here is the question that we saw in the first, the one with the left anterior descending and left lateral circumflex. Yeah, so so most of the MI questions, they will have several options in treatment. For example, if they give you diuretics and even diuretics or nitrates in the option, they will also give you like clopidogrel, aspirin, they will also give you heparin and pain control and everything. But make sure you don't choose any of this, because these are not definitive treatment. Even if it's a heart failure or even if it's an MI causing heart failure, these are not a definitive treatment. If it's an MI, it's mostly should be revascularization. Okay, or if revascularization is not given, it should be thrombolysis. Yeah, thrombolysis or surgical revascularization. Or if it's a heart failure, it should be diuretics or furosemides. Okay, if it's a right heart failure, it should be IV fluids. Make sure you don't select these options. These will most definitely not the treatment, because they are asking about the life-changing management. These are these things we usually give it first, even before they are taken to the revascularization technique. But still, these are not the life-changing management, so that will not be the answer. It will be either revascularization, it will be either diuretics or nitrates, or it will be IV fluids. Okay, just don't do that mistake. Yeah. Okay. Um, okay. So here, what happened? Yeah, you can skip this. Okay, fine. So here is the cardiac changes in the normal heart, aging heart. Um, yeah. So what happens in an aging heart is that I think most of the things you would have by hearted by now, but I will tell you things where you will make mistakes. Okay. So aging heart, first the cardiac myocytes dies. To compensate that dying cardiac myocytes, the remaining myocytes will hypertrophy. Okay. And also there comes some collagens will start to deposit in between this myocytes. Okay. So the remaining myocytes hypertrophy and the collagens will start to deposit. All of these changes will reduce the ventricle size, right? they will thicken. It is kind of a diastolic heart failure happening in this patient. So it will thicken the heart. So what happens, this thickening heart, this thickened heart will reduce the end diastolic volume. Okay, but remember all the remaining myocytes which are there, they are still functioning well, they are contracting well. So the cardiac output or the stroke volume or the ejection fraction, all this will be normal in this patients. This is aging patient, right? You should remember that. Okay, aging patients, so they're normal, they are not all elderly patients are going for heart failure, right? So they will have normal cardiac output, they will have normal stroke volume, they will have normal ejection fraction. Only thing that will decrease here is the end diastolic volume, because the cup size is reduced, the ventricle cup size is reduced, that you can remember it. Okay, and one more thing is, because as I said, like there is a lot of collagens and depositing and myocytes are getting degenerated, that can also affect the what is that, conduction pathway, right? So if the conduction pathway is affected, then the heart rate will fall. Okay, and this is, if it is affected too much, that's when the Mobitz type 2 or complete heart block happens. That's a different story. But normal patients, they already will have a lower heart rate because of the conduction pathways or getting fibrosed a little bit. They might have a little lower heart rate. Okay, that also can happen. And one more thing you can remember is that they usually have this sigmoid shape. The reason is that this collagen deposition, they doesn't happen in a regular manner and all. It just irregularly deposits, and mostly the infundibulum part, it is usually the infundibulum part that is affected everywhere. So even here the infundibulum part is affected a lot. A lot of collagen will be deposited, and that will give you a sigmoid shaped septum. In the septum, instead of being uniformly thickened, it will be like sigmoid shaped in these patients. Okay, and there could be some because of this and there could be some dilated aortic root as well, that is also related to the collagen. Okay, if you come here, you can see that in the aortic stiffening, yeah, you know that all the, as a patient ages, their blood vessels will start to stiffen, right? So that is the same for aorta as well. So aorta also will start to thicken, and that is because of the elastin is being replaced with the other types of collagens, and that will cause isolated systolic hypertension. Okay, this is why we saw the blood systolic and diastolic hypertension there. So whenever the blood vessel is getting thickened, the resistance is increases, the systolic blood pressure is the one which is getting affected predominantly, right? So that will cause isolated systolic hypertension. That is the reason why many elderly patients will have isolated systolic hypertension, and they will have increased pulse pressure. And this is something you see commonly in all question stems in the U world. Most of the elderly patient, like anybody with more than 70 years, they will have increased systolic blood pressure, decreased diastolic blood pressure, and this is normal for them because this is a normal aging process that you have to understand. That's why this is explained. Some question stems, they will have a normal decreased diastolic blood pressure, increased blood pressure, systolic, and that is causing increased pulse pressure in these patients. This is nothing but a isolated systolic hypertension diagnosis. It is nothing more. If they simply explain, some questions can go, mostly in step 2 questions, they will ask very basic stuff sometimes. So they might explain a normal patient and they will give a normal BP like this one, and they will ask you what is the diagnosis. It is an isolated systolic hypertension. So in an elderly patient, if he is having a widened pulse pressure, it is normal for him. So the diagnosis is isolated systolic hypertension. You can remember it if you want. The other changes are the same as we discussed, like resting EF. All this condition in resting will be normal, but what happens if the patient is exercising, the cardiac output is supposed to increase, right? It will not happen. So the maximum cardiac output is lower for this patient. You can just remember an old man, he can walk normally but he cannot run, right? So his maximal cardiac output is low, but the rest of the cardiac output, EF and SV, everything will be normal. But one thing you have to remember, this in diastolic volume, it is definitely decreased because he has smaller chamber compared to the others. Okay, that thing you can remember. And one more thing is heart rate. Heart rate is decreased in all time. Like even resting heart rate is increased, maximum heart rate is decreased. Sorry, resting heart rate is decreased, maximum heart rate is decreased. Everything will be decreased. And one more thing is, I saw one question in UWorld, I think, from this concept, like it's like the baroreceptors will be, sensitivity of these receptors will be decreased. But because the sensitivity is decreased, there's a lot of catecholamine being produced in these patients. So they will usually have an increased circulating catecholamines, but they will have decreased sensitivity to the baroreceptors. That, I think I saw one UWorld question. There is nothing in NBMA or anything in that concept. That thing you can remember. Because of the low baroreceptor sensitivity, they have orthostasis. I think this thing, many elderly women could have encountered them. So this is also normal in elderly. Okay. Let me see if I missed something. Yeah. Uh, yeah, this allows for main. Yeah, so this is because of reduced left ventricle compliance. That is also because of the thickening of the left ventricles, and there is reduced in diastolic volume, which is also something we discussed. Yeah. Yeah. So can we stop here? Um, yeah. Is it like